presentation of this session will be done by Professor Fernando Jimenez from Spain about calf injuries beyond tennis leg.
Thank you, Daniela, for presentation and for invitation. This is the subject. We'll talk about calf injuries. Is a very frequent muscle injury in the leg. I don't have a conflict of interest. This is the anatomy of the calf, and we distinguish two kinds of injuries depending on the frequency. One of them are affecting the anterior, the lateral, and the deep posterior compartment. In the anterior compartment, the extensor muscle. In the lateral compartment, the peroneus longus and brevis, and the posterior profundus. In the proximal area, the popliteus muscle, and in the distal area, the flexor. But it's less prevalent injuries, muscle injuries in this area. The very frequent affect gastrocnemius, especially gastrocnemius medialis and soleus muscle. For us, it's very important the Munich consensus because this classification can be applied to the ultrasound exam. There are another classification, but using the CCI. So this classification has the focus in the MRI, but in the Munich consensus, the classification can be used with the ultrasound examination. We distinguish both kind of injury without histological changes. Is fatigue, DOMS. Another kind of injuries affecting the fibrillar tissue, and so we can see perfectly by ultrasound. The minor partial rupture is complicated because in some time the changes in B-mode exam are smaller, and so sometimes in elongation or distension the diagnosis is hard. But in the moderate partial muscle tear and subtotal is easy. We can use the ultrasound device for this diagnosis. Another injuries affecting this area, for example, hernias, vascular malformation, and fibrosis or cicatrization, etc. Is the ultrasound very good tools. In this case, we distinguish two details about the clinical sign. The gastrocnemius normally has the acute onset with sudden pain and audible click. The swelling is severe. Is accompanied by pain and obvious incapacity. But in the soleus, the onset is subacute. Sometimes the pain is intermittent. The patient can walk even a lot in 2-3 days, and after 3 days he feels pain again, stop 2-3 days, and again the patient feel not pain, and so is confused about the diagnosis. In these cases, the ultrasound and MRI is very useful. The differential diagnosis is with the another muscle. and with deep vein thrombosis. Is more frequent in the gastrocnemius because this is the biarticular muscle. The gastrocnemius cross two joints, knee and ankle, and soleus only cross the ankle. For this reason, and also for the kind of fibers in the gastrocnemius, the injuries are more frequent. But now is the moment to examine the sonoanatomy. We distinguish the posterior fascia or superficialis fascia, the anterior or deep aponeurosis, and also the belly or the intrasustan muscle. And another portion, important portion, is the insertion in the femoral condyle. This anatomy or sonoanatomy is important to do the classification of injuries in the gastrocnemius. Pay attention, there are a lot of classification. Even the last year, this is the 2021, but some of them are very complicated. In my point of view, it's easier to use this classification with 4 types of injuries. One of these is the myofascial rupture. This portion is affected. In the other cases, the myoaponeurotic break affecting the anterior fascia. In other cases, we can find the rupture inside of the muscle. And finally, we can find the injury in the proximal attachment, okay? With this schema, now we are viewing different injuries. This is the sample with the myofascial rupture. The tear is in the myofascial area, the distal part of the muscle, and is affected the posterior aponeurosis. Normally, the hematoma is very wide, normally. In this case, the rupture can extend to the distal part, even affecting the proximal portion of the Achilles tendon. The second kind of injury in this muscle is affected the aponeurosis. And we seeing the perimysium rupture and appear the anechoic or hypoechoic area between the muscle and the posterior aponeurosis, and is very different to the other kind of injury. And normally the hematome is smaller. And another kind, this is in the area of the rupture. In this case, the perimysium is break, and so appear the anechoic fusiform rupture between fibers and the anterior aponeurosis. The third kind is less frequent, but sometimes we find the edema area, hyperechoic area inside of the muscle. Is not affected the fascia, posterior fascia, and the anterior aponeurosis. And normally the hematoma is absent. And finally, the fourth kind of injury affect the attachment, the proximal attachment. And we see the heterogeneous area in this portion close to the tibia. It's important to examine the semimembranosus tendon in this posterior face of the tibia, medialis tibia. The fibular pattern is lost, and we find small areas of the hematoma. And so this is important to distinguish the four kind of injuries in the gastrocnemius muscle. Is in the posterior fascia, in the aponeurosis, in the belly, and finally in the proximal attachment. The second muscle is the soleus. We distinguish both kind of injury in traumatic injuries and intrinsic injuries. Normally, until few years, we saw this injury for doing this diagnosis. We need the MRI always, but now we can identify, probably because the devices are and the probe are more has more resolution. We can identify some injuries. The first kind of is myoponeurotic lesion. Is similar to the gastrocnemius. The second is intramuscle rupture, and finally in the distal portion. This is the two example of acute and chronic injury in the soleus. As another muscle, when the patient has the antecedents of traumatic problem, we see the hematome inside of the muscle. But when the patient suffered the injury before some weeks or months ago, it's possible to identify the fibrosis, and in this case, the hyperechoic injury is clear. But the most frequent problem for us is diagnosis, doing the diagnosis in the intrinsic injuries. This is the first kind of injury, the myoponeurotic. We can see the aponeurosis of both muscle is thickened, and also, we identify the rupture of the perimesion, like the anechoic area close to the aponeurosis. This sign is very pathognomonic, and so always I like to look for this image. Now we are viewing the video. This lesion is similar, is myoponeurotic injury, and we see the anechoic defect close to the aponeurosis in this part, because now we are viewing the gastrocnemius muscle with its characteristic normal, no? And so only the injury affects the soleus muscle. Now we are viewing the number 2 of lesion in the soleus, and we identify the same ultrasound signs of the gastrocnemius rupture, is the edema inside of the muscle, and so we see with more difficulty the fibrillar pattern. In this area, this is in this image, in this area is the injury. But you should pay attention a lot when you see this image in the distal fibers of the soleus, because normally we examine the proximal portion of the soleus in relationship with the gastrocnemius, but it's necessary don't forget this area. When you find this problem, this rupture in this fiber, the risk of injury, of rupture of the Achilles tendon is bigger. And so always you should review this portion of the distal soleus. Another patient with the similar image in this portion, in this case is in the medial part. Now we are viewing the soleus fiber. This is the flexor digitorum below to the plane of the soleus, and this is the same with the Doppler. In this case, the Doppler help us to confirm the diagnosis. But it's very, very important to examine this portion of the soleus muscle. Sometimes the injuries can be combined. Sometimes the gastrocnemius medialis with the soleus. In other cases, we can evaluate the rupture affecting, as in this case, both in heads of gastrocnemius. Normally, when you identify the rupture in the gastrocnemius, you forget the possibility of the soleus can be torn also. And so it's very important to review both muscle, or in this case, the both heads of the gastrocnemius. When you apply don't work, sorry. When you apply the Doppler, can you confirm the diagnosis? Another muscle, less frequent, but you can find a difference ultrasound sign. This is the normal popliteus. This is the popliteus when it's torn. This sonoanatomy image is very beautiful because we see the popliteus muscle with the intersection with the soleus. This is the bed, and in the above we find the gastrocnemius medialis. With this image, we can compare the fibular pattern in both muscle. In this case, we compare in both legs. This is the image. Is not frequent in this injury, but sometimes, especially when the patient feel pain in the posterior aspect of the knee. Normally, you think about the osteoarthritis, or you think about the meniscus problem, but you forget the muscle, and it's very important to review. Another injury is the rupture of the plantaris muscle. It's not frequent, but it's very important to identify. This is the pattern of this muscle in the distal part, the plantaris. We see the three-line hyperechoic line between both muscles. It's very clear. It's very easy to find. But when the muscle is, and this muscle is torn, disappear this three line. We find this not homogeneous image. Even it's normal to find the widening of this tendon. This injury can be combined with the gastrocnemius rupture or not, and so it is very important. The prognosis is better when only is torn the plantaris muscle. Finally, we don't have more time, but only comment the possibilities that the ultrasound give us to diagnose another injury. It's a pity because this video don't work. You should remember that when the muscle is relaxed, you see the hernia, muscle hernia, and when the patient do the contraction, the hernia disappears. With the Doppler, even you find the vessel crossing the fascia. In these cases, the diagnosis is easier. Sometimes when you see the patient with posterior pain in the calf, and the muscle is normal, the MRI is normal, you should look for the point, the place, a small place where the fascia is broke. And so in this place, you do the dynamic maneuver to check if the patient has this kind of hernia. The surgical treatment is easier, is open the fascia, and with this, the problem is solved. And another question, probably less important, but in some cases after the trauma or in patients with diabetes, is necessary to check the edge depth presence of false tissue, etc., to see, to control, to check these ulcerations. And finally, sometimes we can find the Baker sheets. Baker sheets encapsulated or not. In this case, in the video, okay. In the video, we see the Baker sheet break, but encapsulated some weeks after the rupture. And the patient keep the pain. You find this image. Normally, can think about trauma or about Morel-Lavallée effusion. But it's very important to reach the place where is the semimembranosus bursa, because in this place, close to the tendon, between the head of the gastrocnemius medialis and the semimembranosus muscle, in this place is the origin of this bursa. In this place, you should look for the origin of this encapsulated Baker. Finally, only 3 details. The medial gastrocnemius is very easy to diagnose. The ultrasound, or better, the clinical sign is very clear. But in the other case, the soleus present the subacute clinical sign, and the diagnosis is sometimes very hard. Normally, if you have doubt, you should look for look at the MRI. And always in ultrasound and the muscle examination, the dynamic maneuver is very, very useful to confirm this kind of injuries. Thank you very much for your attention.
I really want to thank you for this presentation. I have a lot of cases, so everything you say